So just to check your understanding of the concepts presented in the last slide, let's take a look at the quadriceps muscles. More specifically, the rectus femoris as shown here right in the front of the thigh. As most of you are already familiar with, the rectus femoris is a muscle that crosses two joints, just like the biceps femoris of the hamstrings. It attaches here on the proximal end to the anterior inferior iliac spine, which is its origin, and attaches on the distal end to the base of the patella, which is the insertion. The rectus femoris comprises of two heads. The reflected head, which is the lateral head, and the straight head, which is the medial head. And each of the rectus femoris heads has its own tendon on the proximal end. However, the two tendons, as you see here, are integrated into one large tendon. So let's take a look at this proximal tendon carefully. As you can see, this tendon runs down the middle of the rectus femoris, and the reflected and straight head tendon runs along the inner edge of their respective rectus femoris head. We can also see that the tendon runs almost 50% the length of the rectus femoris. And the shape of each head is a pennant. You can see the angular direction of the fibers here. And all together, this forms a bipennate architecture for the rectus femoris. As I said earlier, pennant-shaped muscles are associated with relatively larger tendons and thus have greater MTJ area. In this figure, you can imagine the MTJ located along the entire length of the tendon edge on both the reflected and straight heads. So this is why when there's a strain, as shown in the prior MRI image, the edema shows up in a feather-like pattern, since the ruptures occur all along the edge of this tendon, both on the reflected and straight heads. Now, since we're on this topic of the quadriceps muscle, just as an FYI, most quad strains to the rectus femoris occur on the proximal MTJ. One reason is that the MTJ region associated with the proximal tendon is very large compared to the MTJ area associated with the distal tendon. And you can clearly see that in this figure. Also, maximum eccentric contractions of the rectus femoris during sports typically occur when the external forces act on the hip. First, remember, a strain usually occurs when there is an external force that pulls on the muscle, while at the same time, the muscles contract, producing force in the opposite direction. In other words, the contraction force shortens the muscle. So in order for the external force to pull on the rectus femoris, the external force must cause an extension of the hip, such as during the backswing before a max effort kick. During the backswing of the leg, there is a very rapid application of an external pulling force on the rectus femoris. It stretches it out. And right at the end of the backswing, as the rectus femoris is being pulled or stretched, there is a rapid contraction of the rectus femoris to 1, stop the backswing, and 2, to initiate the forward swing of the leg. So at this point, we have a situation as reflected by these arrows overlaid on the image in which you have a large external pulling force on the rectus femoris during the momentum of the backswing. And then you have the contractile force, a maximum effort contractile force applied in the opposite direction, represented by the smaller blue arrows. And the area in between these opposing force vectors, you have that large MTJ area highlighted in these red circles. So right at the transition between the back and forward swing of that kick, there is a very rapid external pulling force coupled with an opposing contractile force of the rectus femoris. This is the moment where a maximum eccentric contraction is produced very rapidly. And this is the point of the kicking motion where the rectus femoris experiences the most tension and the fastest tension development, particularly at the MTJ sites, all along the edge of this proximal tendon, both on the reflected and straight heads. And at this moment, as you know, the strain risk is highest. So to summarize, when an athlete experiences a quad strain during a max effort kick, like during a field goal attempt in football, the strain occurs usually during that transition between the back and forward swing, and the strain likely will occur on the proximal MTJ. As for the Ys, The transition between the back and forward swing involves two opposing forces on the rectus femoris, creating high amounts of tension at the MTJ, which is a large area on the proximal end of the rectus femoris. There is the external force that pulls on the muscle because of the momentum of the backswing, and the opposing contractile forces applied to stop the backswing and initiate the forward swing. This creates a lot of tension, or a very rapid rate of tension development, at the proximal MTJ, which is the area between the two opposing forces. And if the tension is too high, say because the GTO didn't respond fast enough, there could be a rupture and thus a strain. So if I present this scenario on an exam, you should be able to answer questions regarding when during max effort kicks would a quad strain occur and why, as well as where on the rectus femoris the strain would likely occur and why. All right, so now that we've covered strain diagnostics and non-modifiable risk factors, let's begin our discussion on post-injury care. Now, fundamentally speaking, especially for athletes, the ultimate goal of post-injury care, which generally includes acute treatment all the way to rehabilitation, is one, to achieve functional recovery, and two, to achieve functional recovery in the shortest time possible. So what is this concept of functional recovery? It is pretty much what the term implies. It is the restoration, ideally the full restoration, of muscle function capacities as assessed by a valid measure of muscle function, namely strength. And this is relative to either the uninjured contralateral limb or prior baseline data of the muscle that was injured. And this definition is very specific to the athlete because functional capacities like strength, and more importantly, the recovery of said functional recoveries, should be as objective as possible to ensure that the athlete does not return to sport prematurely and increase the risk for re-injury. For example, in the earlier days of sports medicine practices, athletes would often return to sport when pain subsides to a tolerable level, or just simply when there is no more pain, when in actuality, the muscle is still healing and not back to its pre-injury functional state. As a result, there was a high prevalence of re-injury and performance decrements because the athletes returned to sport with a vulnerable, partially injured muscle. Without some objective measurement of function, the athlete nor the sports med practitioner would be able to ascertain whether the injured muscle is fully recovered. The only way to assess this is to implement some assessment of function. So this is why functional recovery is the primary determinant of the return to sport status. Now, functional recovery is initially assessed on the muscle in isolation, and then later assessed as part of the intact muscular system. In sports, muscles usually don't function in isolation, but as part of a whole body movement, such as during running, jumping, kicking, throwing, etc. So not only is the recovery of function of the muscle itself important, but also the recovery of performance in sports-specific movements. So for example, after a quad strain, just because the athlete has restored their leg extension strength does not mean that they are ready to return to sport. The athlete must also be assessed in the performance in sport-specific movements like jumping and running, movements that involve the quadriceps muscles. This alludes to the fact that for athletes especially, there is a huge element of strength and conditioning and sport-specific training as part of their rehabilitation program. So overall, functional recovery for athletes is therefore relative to the functional demands of the sport they play. Now, in relation to the initial assessment of functional recovery for the injured muscle in isolation, we have many different types of testing procedures and technologies, many of which we incorporate within the experiments we conduct in my research lab. So for example, we have an isokinetic dynamometer as shown in the figure here to the left. And this is a machine that allows one to test muscular strength during a given joint action. This machine allows for one to perform the joint action with controlled velocity to assess concentric and eccentric strength individually, or perform isometric contractions at different joint angles, all of which are ideal testing conditions for injured muscles to test the strength of muscles almost in isolation. Generally speaking, there are 4 sensors within the machine that will display its data onto the computer so that you can assess the strength of muscles during an isolated joint action like a knee extension, and you can assess this objectively. Other variables associated with muscle function include muscular power, which is a function of both force and velocity, so a measure of not only how much force the muscles can produce, but how fast that force is applied. Other measures include range of motion, which can be easily assessed through the use of a goniometer or some recent video analysis technologies, which are accessible through simple-to-use mobile applications or through less accessible lab-grade video or motion sensor equipment. With the same equipment, we can also assess kinematics, which describes variables associated with movement characteristics, such as angular velocity of joint actions, gait patterns, or joint angles. We can also use electromyography, or EMG, to assess muscle activation by the nervous system. This type of sensor technology can be used in conjunction with basic to advanced strength tests to determine the neural activation of the injured muscle. The data that we acquire from EMG is reflected here on the right, which demonstrates the raw EMG signals as the amplitude of the electrical signals that are responsible for contractions. So for example, if we do a max effort bilateral knee extension test, we could see that the injured limb produces not only less force, but with less EMG amplitude versus the uninjured contralateral limb. And therefore, we can conclude that the injured muscle has yet to achieve full functional recovery. Of course, in many cases, these assessment tools are not very accessible, but the more resources you have to implement these types of assessments and gather more data concerning the athlete's muscle function, the better chance the athlete does not return to sport prematurely, which would lead to optimal performance and re-injury prevention. Okay, so in summary, functional recovery is the end goal following a muscle strain, and this involves the restoration of the injured muscle back to a pre-injury functional state, both in terms of isolated muscle function and whole body performance specific to the sport. And again, to emphasize, functional recovery for an athlete is relative to the demands of their sport. All right, now let's get more specific in terms of functional recovery. The functional recovery that was described in the prior slide is more specifically referred to as late functional recovery. The term late representing this is the functional recovery that is achieved at the end of the rehabilitation. Therefore, late functional recovery is the end goal following the injury. Therefore, everything we do in terms of injury care, from acute treatment to rehabilitation strategies, is to facilitate late functional recovery. We want to optimize it. And this is so that the athlete can return to sport faster and with minimal risk for re-injury, in addition to optimizing performance. So fundamentally speaking, what is the most important factor to improve late functional recovery? As shown here, the most important factor that would optimize late function recovery is structural plus functional healing. So if you revert back to our prior lecture series, which form of healing provides both structural and functional healing? Is it regeneration or scar tissue formation? The answer is regeneration. Remember, scar tissue formation only provides immediate structural healing to provide structural support to the ruptured muscle by forming connective tissue between the ruptured ends of the muscle. This is occurring while regeneration initiates and proceeds. Think of it as a biological stitch to keep the ruptured ends of the muscle intact and to provide some form of structural integrity to the injured muscle. The scar tissue forms relatively fast compared to regeneration, and if scar tissue becomes excessive and permanent, then you would say the muscle healed poorly and there was poor quality healing. So because regeneration and fibrogenesis/scar tissue formation are normal processes following an injury, the ultimate goal post-injury is to improve the regeneration to scar tissue formation ratio. We want to have more regeneration than scar tissue formation to achieve quality healing that is both structural and functional through the reconstruction of muscle. This, at least in concept, is how one would improve late functional recovery, to optimize late functional recovery. And this should make sense because in order for muscle function to recover fully back to a pre-injury state, your muscle needs to replace the damaged tissue with functional muscle fibers and not with connective scar tissue. Why? Because muscle fibers contract, connective scar tissue does not. Also, besides its effects on reducing late functional recovery, remember, fibrosis and permanent scar tissue in the muscle can also leave the muscle susceptible to damage and strains because, again, the permanent scar tissue will form new mini MTJs and thus weak points within the MTU. All right, so to summarize thus far, the ultimate goal following a strain is to implement interventions that would maximize structural and functional healing, which is achieved through improving the regeneration to scar tissue formation ratio. And in this lecture, we will discuss how we can support this through careful acute treatment and rehabilitation approaches. Now, another term I want to introduce here before we delve into it in more detail later on is early functional recovery, aka early mobilization. This is the concept of facilitating the use of the muscle earlier in the post-injury phase for the purpose of optimizing late functional recovery. I'll say that one more time. Early functional recovery is the concept of facilitating the use of the muscle earlier in the post-injury phase for the purpose of optimizing late functional recovery. This is what the term early mobilization is referring to. It is about getting the muscle to the point where you can achieve some mobility and thus some early recovery of the muscle function. Simply put, you want to make the muscle somewhat functional as early as possible to help better optimize the full recovery of muscle function, i.e., late functional recovery. So generally speaking, what do you think would help facilitate early mobilization and thus early functional recovery? Well, first you need to understand what the major limiters to muscle function are in the early post-injury phase. We said that the three limiters include ultrastructural damage to the muscle fibers, motor neuron denervation, and pain/nociception. So of these three, what do you think is the factor that can be immediately addressed to help reduce the limitation to muscle function early on? It would be pain. So careful, and I repeat, careful and controlled pain management is the primary approach to allow for early mobilization and early functional recovery. Again, to help optimize late functional recovery so the athlete can effectively return to sport. Now, later in this lecture, we will discuss this concept further and, of course, talk in much more detail about pain management and the different factors we must consider to avoid disrupting regeneration. I alluded a few times now about certain pain management approaches that may reduce pain but compromise the rate of regeneration. So how does facilitating early mobilization and early functional recovery optimize late functional recovery? The main connecting piece is loading and thus exposing the muscle to appropriate levels of tension in a progressive manner. So if an athlete was able to recover some muscle function earlier post-injury, then the athlete can engage in exercise therapies that involve loading the muscle earlier. And why is that important for late functional recovery? Well, because loading and thus tension is a significant stimulus for regeneration, as well as muscle protein synthesis, which is a part of the remodeling process as discussed in the last lecture series. So we should already understand this to some extent as we are well aware that muscles adapt to loading, more specifically elevated tension in response to contracting against that load. So by regaining some muscle function earlier, we can load the muscle carefully to expose the muscle to some level of tension to facilitate regeneration and remodeling. And I use the words careful and control loading because, of course, in the earlier phase post-injury, the muscle, yes, it is vulnerable to re-injury. It is vulnerable to tension. So therefore, loading needs to be optimized. So we will talk about the concept of early loading in the next couple of slides. So going back to the previous point, one major method of regaining muscle function early, i.e. early functional recovery, is through careful pain management. Since again, pain is the major limiter of muscle function early on, and it is the limiter that we can somehow manage. Now, of course, we have to understand that timing is a critical factor. We don't want to load right away. Remember, we need the muscle to gain some structural integrity before tension can be applied. More on this later. Now, just how I described the early loading of the muscle to be careful and controlled, I also made sure to include the descriptor of careful and controlled when it comes to pain management. Why? Well, for two particular reasons. One, as I said earlier, pain and tenderness, otherwise known as hyperalgesia or high pain sensitivity following an injury, is purposeful because it is a feedback mechanism to protect the muscle from intentional or unintentional mechanical stress. It prevents you from adding unnecessary tension to the injured muscle to prevent re-ruptures while the muscle is vulnerable. So pain management does not mean get rid of all the pain completely or numb yourself of this pain, but rather to control it to the extent where you can regain some function and mobility while at the same time recognizing the pain as feedback. And secondly, as I said earlier, some methods of pain management can be counterproductive as it can have a negative impact on regeneration depending on what you are targeting to mitigate pain. So these are the two reasons as to why it's not just pain management for the sake of early functional recovery and early loading, but rather careful and controlled pain management to gain early functional recovery without re-rupturing the muscle and reducing regeneration. So please remember these points as we move forward and we revisit this concept later on in this lecture. I just want to mainly introduce this concept of late functional recovery and early functional recovery and how early functional recovery, aka early mobilization, and thus early loading of the muscle can help facilitate late functional recovery. Again, more on this later. All right, so overall, optimal late functional recovery relies on the optimization of the 5 phases of strain management. And as I said in the prior slide, early functional recovery is one of the key factors, and that is going to be included within the first 2 phases of strain management. As you can see, the 5 phases of strain management are listed here in sequential order. We have acute treatment, post-acute treatment, functional rehab and reconditioning, athletic reconditioning and specific strength, and finally return to sport. As you can tell, these 5 phases of strain management is specific to athletes and not so much the general population, but of course it can definitely be applied to the non-athletic yet active population as well. So in this current lecture, so in part 1, we will mainly cover the acute treatment phase and introduce the post-acute treatment phase. Therefore, the theme of this lecture is to discuss conceptually and practically how to optimize the acute treatment phase for the purpose of facilitating late functional recovery, which again is the ultimate goal of strain management. So first, the acute treatment phase, which involves the most immediate care following the strain and spans roughly 1 to 3 days depending on the degree of strain. Now, based on the lessons from the prior lecture series, we should all know that the acute treatment phase coincides with the destructive phase and the involved acute inflammation. So as we discuss the acute treatment phase, you should already have a good visualization of what is going on within the injured muscle, particularly at the ruptured site. And this is why we reviewed these details at the beginning of this lecture. So what is the foundation of the acute treatment phase? Some of this I briefly introduced in the last lecture. The main purpose of the acute treatment phase is to 1, minimize the wound gap, and 2, facilitate early mobilization and thus early functional recovery. Why? It is to promote quality healing, which again is defined as greater structural plus functional healing through a positive regeneration to scar tissue formation ratio. And with this, again, the question of why? To facilitate late functional recovery so that the athlete can efficiently get to a return to sport status. Okay, so first, minimizing the wound gap. Before we discuss how to do this, let's make sure you understand why this is important. As you know, the wound gap is simply the space in between the fiber stumps, thus includes the regeneration zones where degradation and necrosis of damaged fiber segments are occurring, and the central zone, which is where the hematoma exists, eventually turning into a blood clot. So if the wound gap is wide, then as you can imagine, there is 1, a greater need for scar tissue to keep the ruptured ends intact and thus a greater chance for fibrosis, and 2, reduced quality of healing since a relatively large degree of regeneration must occur to condense scar tissue and for regenerating fiber stumps to interlace. You can imagine a cut on your skin and imagine the differences in healing between a cut that has a large wound gap versus a cut with a minimal wound gap. In cases of a large wound gap, we would apply some type of stitching to close the wound gap, bringing the ruptured ends closer together. Besides minimizing the risk for infection, the purpose for this is to facilitate better healing quality, greater regeneration to scar tissue formation ratio. As the end goal, we want to eventually fill that wound gap with skin cells that add both structural and functional integrity as opposed to connective scar tissue, and we want to facilitate this as much as possible. So just like skin, ruptures to the muscle and muscle fibers require immediate care to minimize this wound gap. So now the question is, how? How can you achieve this considering we can't apply stitches to torn muscles? Well, there are two things that can cause a wound gap to widen excessively beyond what is created due to the damaged fibers itself. One is edema/hematoma, and the other is excessive degradation and necrosis caused by excessive inflammation. Remember, as inflammatory cells are recruited to the rupture site, they will release proteolytic enzymes and free radicals mainly to further degrade necrotic cell fragments. But in excess, this can lead to the degradation of undamaged fiber segments in the surviving zones, causing further unnecessary necrosis. So remember, acute inflammation is normal and a required process, but the key descriptor is excessive. We want to control excessive inflammation, not totally mitigate inflammation, which you can't do anyway. And of course, with edema at the rupture site, which includes the hematoma, this can widen that central zone within the wound gap. So if edema and hematoma becomes excessive, this can surely widen that wound. And as I'm describing the fundamentals of reducing the wound gap in the acute treatment phase, you should start to realize that the common acute treatment modalities that we are all somewhat familiar with target these two factors, edema/hematoma and excessive inflammation. All right, next. We said that the second purpose of the acute treatment phase is to facilitate early mobilization for early functional recovery. As I mentioned a couple slides back, we want to get the muscle somewhat functional and mobilized as early as possible so we can load it and apply tension, of course, in a safe and controlled manner. This is again to help facilitate regeneration since tension/mechanical stress is a stimulus for regeneration, as well as anabolic processes such as protein synthesis, which is critical during the repair and remodeling phase. So let's again review the three factors post-injury that limit muscle function. They are 1. Ultrastructural damage to the muscle fibers, 2. Motor neuron denervation, and 3. Pain or nociception, also referred in medicine as hyperalgesia, which is increased sensitivity to noxious stimuli. We can describe this also simply as tenderness. So in order to facilitate early mobilization during the early post-injury phase, we need to somehow mitigate those three factors that limit muscle function. Well, for the first two, ultrastructural damage and motor neuron denervation, there's not much we can do about this during the acute treatment phase. Remember, we are still in the destruction phase. Repairing the ultrastructural damage and reinnervating motor neurons occur during the subsequent repair and remodeling phases. So what is the only factor that we can manage somehow during this early phase? It's pain. We can manage hyperalgesia or tenderness through a variety of modalities that are collectively referred to as analgesics. Now, of course, we will discuss these analgesic modalities and the concepts of pain management in much more detail later on, but fundamentally speaking, how can we manage pain? How can we reduce hyperalgesia? So first, let's review how and why pain occurs following a strain. So as we know, pain requires the process of nociception, which is a mechanism by which sensory neurons called nociceptors respond to an elevated presence of a noxious stimuli by sending quote-unquote possible threat signals to the spinal cord and the brain, the central nervous system. If the brain perceives the threat as credible, it creates the sensation of pain to direct attention to the body part and to prevent perturbation to that area, so the threat can hopefully be mitigated. So what are the noxious stimuli at play here following a strain? First, we have chemical noxious stimuli. Chemicals released by inflammatory cells, therefore inflammatory chemicals, as well as those that leak from damaged muscles, can accumulate at the rupture site and become noxious. Therefore, following a muscle strain, acute inflammation has a large role in providing that noxious stimuli for the nociception. And greater the inflammation, the greater degree of nociception and thus pain. These chemicals, keep in mind, serve purposes such as regulating inflammation and initiating healing. But in high amounts, like following a strain, they can also trigger the chemoreceptors on surrounding nociceptors, thereby causing nociception. This mechanism specifically is often associated with the perception of muscle soreness following an injury. We also know that the injured and sore muscle is hypersensitive to mechanical stress, like when you contract, stretch, or make contact with the muscle. This is often described as tenderness, but more technically as hyperalgesia, as mentioned earlier. Remember, hyperalgesia simply means an increased sensitivity by nociceptors to a noxious stimuli. So how does hyperalgesia work following a muscle strain? As we introduced in the prior lecture, during inflammation, the accumulation of chemical noxious stimuli increases the sensitivity of nociceptors to mechanical stimuli. So a level of mechanical stress that is not normally noxious and would not trigger pain will now trigger pain. This means that during inflammation, the mechanical nociceptors have a lower stimulation threshold for nociception. I'll say that again. During inflammation, the mechanical nociceptors have a lower stimulation threshold for nociception, meaning it doesn't take a lot of mechanical stimuli to trigger these mechanical nociceptors. In other words, the mechanical nociceptors, more specifically the mechanical receptors on these nociceptors, become hypersensitive. This is what contributes to the tenderness or hyperalgesia to the injured muscle. This is the mechanism that explains why even with a light stretch or contraction of the injured muscle, there is sharp pain. Overall, the hyperalgesia prevents you from mechanically perturbing the injured muscle for the fundamental sake of protecting the muscle from tension while it is in a vulnerable state. So the dilemma here is that we want to reduce this hyperalgesia so we can add some mechanical stress to the muscle to facilitate early functional recovery, to promote quality healing and optimal late functional recovery. But at the same time, we don't want to mitigate the pain to the extent where we are not receiving the necessary feedback to control the amount of mechanical stress to the muscle. Of course, if we totally eradicate the pain, if we completely numb ourselves from the pain, and there's ways you can do that, then we will create a problem because you would end up adding too much mechanical stress prematurely by, say, loading the muscle too much and performing exercises that would increase the risk for re-rupture. This is because there is no pain to avert this behavior. So pain is necessary, as I emphasized many times before, but excessive pain and hyperalgesia should be managed carefully so that you can begin adding some mechanical stress to the muscle to facilitate early mobilization and early functional recovery so that you can eventually load the muscle progressively and exercise the muscle progressively to stimulate regeneration and promote quality healing. So as indicated here, the way we manage pain in the acute treatment phase may or may not be through targeting inflammation. Of course, by reducing inflammation, that would reduce hyperalgesia since the chemical noxious stimuli would be minimized. But as I've alluded to many times, the question is this the ideal approach? And this question arises from the fact that the same chemicals from inflammation that trigger pain also regulate inflammation and initiate healing. So in this lecture, we will discuss the different targets for pain management and better understand the most optimal approach to pain management. All right, just to reiterate, remember, acute inflammation, edema, and pain are biologically purposeful. They have their specific roles. They are not just there to make life hard, but controlling excess would be beneficial, again, for the sake of one, minimizing the wound gap, and 2, facilitating early mobilization and early functional recovery. These two factors are again significant to supporting quality healing through higher regeneration to scar tissue formation ratio, and in turn supports late functional recovery. All right, so over the years of research, acute treatment principles were established based on the information I just discussed. These principles are intended to guide the practitioner in acute treatment settings. In sports, this would most likely be an athletic trainer, although with severe cases, an orthopedist would likely get involved early on. So the traditional principle that was established to guide acute treatment practices was the RICE principle, R-I-C-E. This mnemonic stands for rest, ice, compression, elevation. Not too soon after, the PRICE principle was developed as illustrated here, and the added P representing protection. The PRICE principle has been the go-to principle on which acute treatment strategies are based on, but it has continued to evolve. So more recently, there has been some changes to the PRICE principle, which I'll get to in a second. So first, let's go over each of the components within the PRICE principle and introduce the recent changes as we go through it. First, there is protection, which is pretty straightforward. This includes why you should protect the injured muscle. This is solely for the sake of preventing unnecessary damage to the muscle beyond what was created by the strain itself. Unnecessary damage can happen especially with some type of mechanical disturbance to the injured muscle, whether it is through an intervening contraction, stretch, pressure, or contact. At this point, immediately following the injury, repair has not begun, so there is no connective scar tissue that has formed at this point to provide some structural support to the ruptured muscle and tolerance to tension. Now, keep in mind, protection does not infer complete immobilization. So, for example, the use of a brace or crutches can provide the athlete with the ability to mobilize without placing inappropriate amounts of stress on the injured muscle. Next, we have rest, which is the most immediate action that should be taken upon injury. This works in conjunction with protection, in the sense that rest is essential to avoid unnecessary and inappropriate amounts of mechanical stress to the vulnerable injured muscle. Now, as you can see right here, there is a giant red asterisk next to the letter R. This is indicating the recent modification to the PRICE principle, as I alluded to earlier. With recent evidence, rest has been replaced with optimal loading, which includes elements of rest, but also includes appropriate amounts of loading or mechanical stress to the muscle. Optimal loading is a progressive loading strategy, much like you would with resistance training. However, instead, you are starting with very minimal loads, which often at the early stages are afforded through manual resistance from a trainer or therapist, also known as manual therapy. The reason why optimal loading has been included as part of the acute treatment principle is because loading, and thereby the tension, stimulates regeneration. Now, paradoxically, crutches, braces, and supports traditionally associated with protection and rest may have a greater role in adjusting and regulating optimal loading in the early stages of post-injury care. Now, just to reiterate, optimal loading is associated with the concept of early mobilization and early functional recovery. Early loading through, say, manual therapies can facilitate early recovery of some muscle function, which again is synonymous with early mobilization. This can then support further progressive loading because the muscle, as it regenerates further, can tolerate more load and tension. This in turn will then further improve mobilization and function, leading the way to quality healing and optimum late functional recovery. These specific concepts of optimal loading and early functional recovery / mobilization will be further discussed towards the end of this lecture. Okay, so to summarize the second part of the mnemonic police / price, the rest should be immediately prioritized, followed by optimal loading, starting around day 3 depending on the grade of strain, and at this time loading should be as minimal as possible and afforded mainly through manual therapy / resistance. Alright, the next modality of police / price is one that is well known, and that is icing, which falls under the category of modalities called cryotherapy. Now, icing has shown to be one of the most versatile acute treatment strategies for soft tissue injuries because it exerts multiple and distinct effects that can be beneficial for the intended purpose of the acute treatment phase, as described earlier. So for now, please understand that icing is applied during the acute treatment phase for 3 specific reasons, which include the following in order of most significance and impact. First, icing is utilized to control swelling. As discussed in the prior lecture, swelling or edema occurs due to the accumulation of intra and extracellular fluids at the rupture site, as well as hematoma, bleeding. One of the reasons why fluid and blood flow is directed towards the rupture site is due to changes in pressure gradients. When the muscle experiences a rupture, so do micro blood vessels around the rupture site. This creates a low pressure environment within the vasculature at the rupture site. As many of you know, blood and fluids flow from high to low pressure. Thus, blood will flow towards the rupture site. So what can you do to equalize this pressure gradient to minimize the flow of blood to the rupture site? One mechanism by which this can be achieved is through the stimulation of vasoconstriction, especially at the rupture site. This is constricting those blood vessels. One potent vasoconstrictor is cold thermal stimuli. So as one places an ice bag or some form of targeted cryotherapy on the injured muscle, this will stimulate vasoconstriction of surrounding blood vessels. This will in turn reduce pressure gradients, thereby reducing blood flow to the rupture site. Now, as a reminder, this is intended to help minimize the wound gap, one of the fundamental purposes of the acute treatment phase. Okay, the second reason for icing is that it has a potent yet very temporary analgesic effect, meaning it helps reduce pain but only temporarily. Now keep in mind there are 2 mechanisms by which icing or cryotherapy can reduce pain. These mechanisms are very distinct. One is through disruption of nociceptive signals, and the other is through a very weak anti-inflammatory effect. The former is a much more substantiated mechanism versus the latter in terms of the analgesic effects of icing. I'll say that one more time. Nociceptive signal disruption is a much more substantiated mechanism versus the weak anti-inflammatory effect in terms of the analgesic effects of icing. Later in this lecture, when I discuss the science of pain management post-injury, I will discuss these mechanisms related to icing and its analgesic effects in much more detail. But for now, just know that the secondary reason for icing during the acute treatment phase is for temporary pain relief, primarily through nociceptive signal disruption, and to a lesser effect, anti-inflammation. Which leads us to the third and least impactful reason why icing is applied during acute inflammation. This would be managing excessive inflammation. Cryotherapy, or icing, has been touted to exert an anti-inflammatory effect on the basis of scientific evidence. However, the evidence also indicates the size of said effects to be negligible to small. I'll say that again. The evidence also indicates the size of said effects to be negligible to small. However, given that excessive inflammation is what needs to be controlled to mitigate excessive degradation and necrosis and thus secondary damage, even a minimal anti-inflammatory effect may have some practical benefits. And of course, as I said earlier, reducing excessive inflammation is one route that can reduce chemical noxious stimuli and reduce pain. But as I said, this is not the most potent mechanism by which icing exerts its analgesic effects. Again, it is primarily through nociceptive signal disruption, which again we will discuss shortly in the upcoming section. Okay, so to summarize the reasons for the application of ice or cryotherapy during the acute treatment phase in order of significance and impact, we have 1. Reducing edema and hematoma, 2. temporary analgesia, mainly through nociceptive signal disruption and minimally through anti-inflammation. And 3, a negligible to small anti-inflammatory effect, which may be beneficial in the case of excessive inflammation. All right, so the next 2 strategies for price or police is compression and elevation, which both serve the same purpose but through different mechanisms of action. Compression, just like icing, serves to reduce edema at the rupture site, but it does this through a similar but different mechanism. Icing reduces edema and hematomas by vasoconstriction of surrounding blood vessels, thereby reducing vascular pressure gradients to reduce blood flow towards the rupture site. Compression, on the other hand, has a similar effect in that it increases the pressure at the rupture site, thus reducing vascular pressure gradients. It doesn't do it through vasoconstriction. So by compressing the rupture site, this will reduce the blood flow and fluids to the rupture site by equalizing that pressure gradient. This is, of course, through manual pressure on localized muscle blood vessels as opposed to stimulating vasoconstriction. And yes, of course, the combination of ice and compression would be ideal to maximize these effects on swelling. Compression is also beneficial in terms of edema control by reducing the accumulation of intra and extracellular fluids at the rupture site. And this is completely aided through the application of pressure on the wound. So overall, compression helps control bleeding and fluid accumulation. Elevation accomplishes the same thing, but instead of pressure to divert fluids from the rupture site, you use gravity. Now, I'm not going to spend too much time on compression and elevation because they serve a very simple purpose: to reduce swelling through the use of pressure on the rupture site or through the use of gravity, respectively. Okay, so as you can tell, the main focus of price and or police is to minimize the wound gap as shown in this familiar figure. Protection and rest are intended to prevent exacerbation of the rupture and therefore wound gap through inadvertent tension. Along with rest, according to the police principle, optimal loading can be applied carefully and progressively around day 3 depending on the severity of the strain, once pain is manageable and some swelling has subsided. This is again to promote early mobilization and early functional recovery, and not so much to minimize the wound gap directly. However, optimal loading can indirectly reduce the wound gap eventually by aiding the stimulation of regeneration. Next, we have icing or cryotherapy, which can help reduce the wound gap through the control of localized edema and hematoma in the central zone, as shown here, as well as through some anti-inflammatory effect to control excessive degradation and necrosis, reducing the expansion of the regeneration zone into the surviving zones. And compression and elevation also helps reduce the wound gap, also through the management of edema/hematoma. So now let's begin to talk in more detail about managing excessive inflammation and how this relates to the management of pain. The reason I want to focus on this subtopic is because it has been a topic of debate and controversy in the sports medicine field for quite some time. There is the ultimate question of, should inflammation be the primary target for pain management following a soft tissue injury? And I would say for a very long time, inflammation has been the traditional target for pain management, especially through drug interventions. So as I emphasized, the initial and temporary management of acute inflammation following a muscle strain, particularly during the acute treatment phase, is to 1. Mitigate excess degradation and necrosis to reduce the wound gap to help support quality healing, and 2. To manage hyperalgesia, since as we know, inflammation accompanies the accumulation of chemical noxious stimuli. And managing hyperalgesia is of course to help not only with comfort, but also with facilitating early mobilization and early functional recovery. Now, in most cases, basic and common anti-inflammatory modalities, namely cryotherapy and non-steroidal anti-inflammatory drugs like aspirin and ibuprofen, when used in moderation, will lack potency in significantly reducing inflammation. Nevertheless, There is a small to negligible anti-inflammatory effect from these modalities that can be practically meaningful, especially in grade 1 and possibly grade 2 strain situations, when the inflammation is not as extreme, relatively speaking. So yes, although the effects on inflammation and the associated degradation and necrosis are minimal, it is still nevertheless meaningful, since a little effect can still be helpful, again, especially when the inflammation is not so severe compared to what one would experience during a grade 3 strain. What we do know, however, with regards to NSAIDs and cryotherapy is that it can provide significant analgesic effects. NSAIDs specifically target certain inflammatory chemicals that are known noxious stimuli, while cryotherapy may indirectly reduce the levels of noxious stimuli by reducing the activity of inflammatory cells that release them. However, please keep in mind that icing or cryotherapy exerts its analgesic effects primarily through a mechanism that has nothing to do with anti-inflammation, and I introduced this fact a little bit earlier. It is rather through a process of nociceptive signal disruption, which again we will get to eventually. So for the most part, controlled use of NSAIDs and cryotherapy is useful to minimally modulate excessive inflammation and to reduce pain, especially with grade 1 to 2 strains. However, the problem and thus controversies come with extreme use of and dependency on these anti-inflammatory modalities. This is because, as I discussed earlier, inflammation is a necessary process to clear the rupture area of debris and promote eventual healing, and thus disrupting this inflammatory process to an unwarranted extent by overusing anti-inflammatories can have detrimental effects on regenerative healing. So why is it that anyone would overuse these anti-inflammatory treatments, especially NSAIDs? It's because they effectively reduce pain, and people generally like that. Thus, overuse of NSAIDs is actually quite common among athletes. Well, as I said, controlled use of NSAIDs has a small anti-inflammatory effect by blocking an inflammatory chemical that is noxious in high amounts. However, this same inflammatory chemical is also a significant factor in regeneration. So with overuse of NSAIDs, you are significantly inhibiting this inflammatory chemical, and the effects are reduced pain, but also reduced regeneration, which would ultimately diminish the quality of healing. So as you can see, the use of NSAIDs following a muscle injury is paradoxical, and later we will discuss in detail the mechanisms underlying these paradoxical effects of NSAIDs. So what about cryotherapy then? Well, I will say that cryotherapy shares the same paradoxical relationship as with NSAIDs, but not to the same degree. This is because cryotherapy does not target any single inflammatory chemical directly. Its anti-inflammatory effects are not only minimal, even with heavy applications, but it is also indirect. So it is not potently inhibiting inflammation to the extent of disrupting it. However, in non-injury, exercise-induced muscle damage situations like following heavy resistance exercise, extreme cryotherapy use has shown to significantly disrupt the small and necessary inflammatory response to exercise-induced muscle damage, to the point where subsequent regeneration of damaged fibers is impaired. And thus, across a long-term period of training and frequent and heavy use of cryotherapy like ice baths, research has shown that the rate of adaptations to training like muscle growth and strength development is significantly reduced because of the accumulation of muscle fiber damage. So if you know anyone who is engaged in resistance training and does ice baths every day for the simple sake of reducing the minimal inflammation and DOMS, you should inform them of the consequences and how it is likely counterproductive to what they are trying to achieve with resistance training. However, we are talking about muscle injury situations. So in muscle strain situations, since the acute inflammatory response is greater than that with EIMD, cryotherapy does not appear to significantly disrupt inflammation and thus regenerative healing, and likely does not compromise the quality of healing. Therefore, between the two anti-inflammatories, cryotherapy would be the most practical and recommended versus NSAIDs in muscle strain situations, that is. What is more so recommended and perhaps more practical, however, specifically for pain management, are analgesic modalities that do not target inflammation. In so doing, there is no worry about disrupting inflammation to the point where regeneration is impaired. So there are a separate class of analgesics that do not target inflammation. The only exception, as we will discuss later, is cryotherapy, which exerts its analgesic effects through both a non-anti-inflammatory and anti-inflammatory pathway. So in the upcoming section, I will go over the nociceptive pathway in much more detail and how this pathway can be manipulated through a variety of analgesics. We will discuss the two major targets for analgesia and the mechanisms associated with each of the major targets. Generally speaking, we have inflammation as a target and nociceptive signal disruption as a target. And as I said, I will discuss in detail the anti-inflammatory paradox associated with the use of NSAIDs. In other words, I will review the pathway through which NSAIDs inhibit nociception, but also inhibit regenerative processes. Before we move on, however, I must note that with severe grade 3 strains where there is an avulsion and therefore very high amounts of inflammation and pain, it is common for a physician to prescribe a steroid-based anti-inflammatory drug, namely corticosteroids. These steroids have a very potent anti-inflammatory effect, which in turn would effectively reduce pain. The reason why a more potent anti-inflammatory agent is introduced with a more severe strain is because the inflammation is extreme. And thus these corticosteroids, for example, are utilized to control that so that we don't have severe secondary damage from excessive degradation and necrosis. Secondarily, these corticosteroids would help with pain management, but it is not the primary intent for corticosteroid administration. Now keep in mind, during a grade 3 strain, since inflammation is usually extreme, the controlled use of corticosteroids would not necessarily compromise regeneration. However, overuse of corticosteroids during a grade 3 strain situation can indeed negatively affect the quality of healing because there could be too much inhibition of the necessary inflammatory processes leading up to regeneration. This is especially critical for a grade 3 strain because the quality of healing is inherently compromised simply due to the severity of the damage. So you do not want to do anything that would further exacerbate this, like overusing corticosteroids or even NSAIDs, and significantly disrupting the inflammatory process. Unfortunately, this is a very common practice among athletes, which contributes to poor quality healing, poor muscle integrity and functional recovery, diminishing performance, and increased risk for future strains and EIMD. Now, as a simple side note, however, there are analgesic modalities that do not have anything to do with inflammation and target nociceptive signal disruption, but are also very dangerous. And I'm alluding to opioids. We will talk about opioids a little bit later on, but I just wanted to put that out there now so you don't get the impression that anything that disrupts nociceptive signaling is the go-to modality for analgesia. There are dangerous ones as well.